everybody, and welcome to OPTIM Manual Therapy's repeated motions lecture on the Cervicothoracic spine. Once again, I'd like to apologize to our OPTIM COMT participants from this past weekend's course as we ran out of time. We thought it was more essential to focus on the hands-on stuff and the lab components that it's harder to teach just through video and through lecture. And, for this lecture, I definitely recommend reviewing the Repeated Motions Foundation and Lumbar Spine lecture first, as a lot of the concepts will come up again and they apply directly to this lecture. So today we're going to talk primarily about the cervicothoracic spine and how the repeated motions can be used for this area. Without a doubt, you also want to be checking for the upper quarter and for the TMJ for these types of patients, depending on your patient's pain presentation, but the goal is to have functional mobility throughout the upper quarter. So as I said, the same concepts are applying from the lumbar spine and foundation lecture. We're going to go over each one of these as briefly as we can, but still getting some detail out of it. So in regard to directional preference, that will be the motion that our patients, if they repeatedly load, we see some kind of positive sign with it. And what is meant by a positive sign is that, one, you could have just a decrease in symptom intensity. You could also have a reduction in the symptom location. And what I mean by that is maybe throughout doing the motion, the symptom or pain becomes more focalized or isolated to one specific spot and not necessarily as vague. Definitely a positive sign. Another one is, the more typical centralization of symptoms where maybe they go down all the way into the extremity, and then as you proceed, they move towards the spine and can even increase in the spine during that process. The patient may have had no spinal symptoms to even begin, but this can help to kind of determine how involved the central aspect is. And one other positive sign is an improvement in mobility as well. And what I mean by that is not just normal range of motion, but also you can see changes with as you're going through the repeated motion. For example, if you're doing the neck, each time you're going through it, it's likely to hurt loading the involved side. But as you continue through it, you might notice you can get a little further before it hurts. So it might have been just going a couple inches initially and it was hurting, but then they can get further and it's hurting. That's definitely a positive sign. And these positive signs can apply not only to the repeated motion itself, but also your asterisk sign. So make sure you're checking with that. So again, if we're doing something for the neck, but the patient's asterisk sign is like reaching overhead, make sure you do your 10, 20 repetitions as an assessment, and then recheck your asterisk sign and see maybe those same things we're talking about, decrease in pain, change in location, going further before the pain, all those can apply as well to your asterisk sign and not just the repeated motion itself. As for any repeated motion, getting to end range is essential. In fact, this is probably one of the key factors that will make your patients look like they're not responding well to a repeated motion. If they're just trying to retract and not getting very far, it might even just aggravate them and they'll complain about stop doing their exercise. And it will likely require frequent education for getting to that end range position for them to start seeing the changes in those symptoms. Frequency is an extremely essential component to this treatment. And again, it comes back to education in that we need our patients to recognize that the more they do this sort of thing, the better their faster their symptoms are going to improve and the better their symptoms are going to be. So I'll tell my patients, hey, I want you doing 10 repetitions an hour, and I'll be lucky if I get anything like that. So I'll have my patients come back in the clinic and I'll show them like, all right, let's do their asterisk sign, 20 repetitions, reassess their asterisk sign. 20 repetitions, reassess the asterisk sign until I get them to realize just the significance of the changes that they can have. And sometimes I'll do 100, I'd say probably 100 is the most repetitions that I've done in the clinic, but I want them doing it regularly throughout the day. What sort of effects can we expect? You can have any changes in neurological symptoms, pain, mobility, strength, reflexes. I mean, if the nervous system can be involved, it can likely be changed by this sort of treatment. If symptoms are just kind of like strange, I'll definitely go towards repeated motions. I had a case where I had this athletic rock climber. I mean, she was about my age, and she rock climbing 3 times a week. So you think pretty good body strength. Well, I assess her glute strength, and I'd give it maybe a 3- or a 3. Clearly couldn't get to end range when trying to just assess the strength, but definitely could hold no resistance at all. And I had her do just 20 repetitions of, for her it was side glides, but each patient, you got to be specific for them. And immediately she had 5 out of 5 strength. So it was some sort of neurological inhibition coming through her lumbar spine. And then lastly, you're going to have to recorrect your patient's posture regularly for this sort of technique. I'll send them home pictures, videos on how to properly do the technique. They'll come back and I thought I was working at first, and it got worse. And I reassess how they were doing it. And of course, they were kind of unloading the position, so it loses its effect completely. So other things, we kind of talked about this. Check for your asterisk sign regularly because you want to make sure you're getting the changes that you're looking for. And always in your upper quarter patients, check the cervical and thoracic spine, no matter what. If they come in with a hand pain, elbow, shoulder, you should start at the cervical and thoracic spine. Just talking about that double crush syndrome perspective, if you have some sort of restriction in the spine, then it's going to make it easier for any peripheral restriction to become apparent. You could also look at it from more of a mechanical perspective as well, in that if you have decreased mobility in the spine, then the shoulder, elbow, hand, they have to take up more stress to get those end range of motions. And those upper quarter mobility restrictions may improve just by doing spinal repeated motions. And then when you're looking for what should be normal for the patient, you want to have your norms. And, I'll use the SMA to start, but the biggest thing is comparing mobility side to side. They may be restricted on both sides, but if they're dysfunctional just on one, you might need to just get them to that symmetrical part, although it's better to kind of keep pushing through it and get them to functional mobility. So for the cervical spine range of motion, you want to assess for normal flexion, extension, rotation, and side bending mobility. And with side bending, I encourage the use of retraction first. And so what that'll look like is you'll have them retract first and then side bend, looking side to side comparisons, keeping that retraction motion. Likely, the symptomatic side, they'll have a decrease of loading on that side. So for me, it would look like the right side there. I personally will use the SFMA or some other form of standardized mobility assessment so that I'm consistent with it. But you can use whatever sort of mobility screen that you prefer. And again, assess these for all upper quarter patients. You want to look for that loss of ability to load. Typically, it's going to be linked to the symptom presentation. So what that will look like, not just the retraction side bend loss, but also when they extend, you'll see them kind of avoid loading that involved side. So for example, if they show dysfunctional retraction side bend to the right, as they extend, their head will start to deviate to the left. And then bilateral or central symptoms will show a difficulty loading bilaterally. So you might not see that deviation one way or the other. But they'll have a hard time side bending each way, or it'll hurt on both sides, and then extending will be restricted as well. One thing to watch out for is you might have a patient where they have pain on both sides, but it's greater on the other, and it might be you first have to start working the one side that's more involved, and then you can start loading bilaterally. So with a loss of side bending mobility, retraction side bending mobility, you want to have the patient repeatedly load into that position. Be sure to maintain the fully retracted position. So you want to retract, side bend, and repeatedly have them maintain that position. As they side bend, their chin's going to want to jut out, and you'll have to correct that. And then you want their opposite arm to sit on their hip, so you take out the tension that might restrict the mobility in the upper trap and scalenes. As those symptoms centralize or become bilateral, you may need to switch to a different sort of repeated motion technique in order to progress towards getting them to 100%. There are a few cases where this technique will not work well, where the patient just has a hard time fully getting to end range with the side bending. And so either you can passively do it for them and just get behind them and maintain that retraction and pull them there, and a lot of times they'll start to see that improvement, or you can have them switch to repeated rotation with side bend. So what that'll look like, if I was going to load the right side, I'll have them rotate their head fully to the right side, and then just do some side bending there. And that'll help get that CT junction and lower cervical area. And once again, these, if you haven't watched the foundation lecture, these sorts of treatment methods do not even consider or don't recognize the significance of pathoanatomical findings. So don't worry about like, oh, I'm crunching down on a nerve, or I'm going to be pushing this disc into the foramina. If you just start talking about that, you're going to tense up the patient, and they'll likely not be willing to even try to get to end range. So you'll be able to tell if these work just by the effect of your assessment and treatment. With central symptoms or symmetrical, you want to have the patient perform repeated retractions. And this is the lower level of the exercise, and that's just going straight back. No need to actually push them into protraction and retraction regularly. And these are for your extension dysfunctional patients, directional preference. The exercise can be progressed with manual overpressure. So if you're going to have them retract, you can use their hand to get just a little further into end range. And then if it's located in the lower cervical spine or the cervicothoracic region, or even they just stop showing progress, what you can do is progress to retraction with a little bit of extension. I usually tell them like 1 to 2 inches. And they'll feel that increase in intensity down in the CT junction. Now, I do want to point out that I'm pointing out the most common repeated motion directional preferences. There will be a rare case where you need to do the opposite. For example, you might have someone that if they have Shirley-Sahrmann's flexion syndrome or flexion rotation syndrome, where they are stuck in like an extended position, you might need to actually encourage they do some protraction. You just need to assess each motion and see what one is best for your patient. I'm giving you the most common ones. When it comes to the thoracic spine, you want to assess this mobility for having the patient's arms overhead interlocked behind their head, or you can have their arms on a dowel, like resting on their shoulders, and then just do seated thoracic rotation. I do not recommend assessing this in standing, as you'll get some lumbar and hip compensations as well. In the seated position with the arms overhead, you're more likely to get the majority of motion coming from the thoracic spine. You want to check for end range loss by just giving a little manual overpressure for each side. And again, typically you'll see a loss of mobility loading the involved side. You want to check this for all of your upper quarter patients. I mean, if you look at the research for shoulder, neck pain patients, elbow pain, a lot of them benefit from doing a thoracic manipulation anyway. So this can help tell you just like if they need a repeated motion to help maintain some of that mobility loss. The actual treatment for it, pretty easy. And actually, this is my go-to for rib treatment exercises. You're going to have them place the fist of their involved side right on the sternum, and then their other hand right on top of that. And you're going to go as fast as you can and as far as you can, repeatedly rotating to the dysfunctional side. So the patients, again, will be a little hesitant at first, but as they kind of go through some motions, they'll kind of build up some confidence, like, oh, this actually isn't so bad. It's okay to, once again, hurt going into that range, but then if it come back and it feels okay, great sign. Just got to keep pushing it. Sometimes it's good to give a cue so that behind the elbow of the side that you're trying to rotate to try and get them a little bit further. You just have them like try and hit your hand as they're rotating. These are called thoracic whips, and it should be more of like a ballistic motion. Like I said, the speed is the most important thing here. Check it with all of your upper quarter patients. And I really like this technique for ribs, especially when it comes down to your floating ribs, 11 and 12. We have a lot harder time doing any of our manual treatments to address those, especially if it's an anterior subluxation. This can help to get that mobility back and calm down any pain or restrictions. So some key things to remember. A high number of repetitions is essential for the speed of recovery. And you're going to probably have to reassess this regularly in the clinic and prove to the patient, hey, look, the more we're doing it, the better you're feeling. And there's usually just like a couple week window where they have to do it really, really, really consistently. And maybe you have to change a little something for them at that point. But you get them to a point where they only have to do it like before they exercise. Even though we're dealing with the cervical spine, definitely recommend a lumbar roll when they're sitting, as it puts the lumbar spine in a more neutral position and then translates up to the thoracic and cervical spine to make that in a less pathological position as well. The symptoms may begin unilaterally, and then as you progress through your repeated motion, they may become central or bilateral. And at that point, you'll probably have to switch to a bilateral loading repeated motion specifically. If the patient is having a difficult time getting to end range, or there's like a fear associated with it, either you're going to have to change their exercise so that they can have an easier time getting there, or do some sort of manual treatment or pain science education to get them to a point that they can move through the motion and get to that end range that's having the effective treatment. And that's it pretty much, guys, as far as this video goes. If you have any questions, feel free to contact me. And for all of our guests watching this video, we hope you liked what you saw with some of the OPTIM content. This is just an example. For more questions, contact any of the faculty members, and maybe joining a cohort is right for you.